may not encompass what exactly you're looking for, but feel free to ask the questions. We feel from a lab point of view, we're going to talk more about the design and how it works and generalize your goals in fitting. The things that we probably won't hit on too much are things that you can use other resources for, INR, insertion removal, or application and removal. We won't talk pricing and that type of thing, or billing and coding. We want to concentrate on what you're doing with Sclerals, getting started with them, and the fitting philosophy behind it. So we'll ask some of these questions, and we'll talk about some of these questions on, why are we doing Sclerals? Obviously, what are the conditions, patient selection, and then when you get into those fitting aspects of it, how do I choose? What do I choose, and how do I go about choosing that? And that determines everything from that point on. We want to talk about what lens size, what diameter, selection, fitting goals, all these various things, and then take it and break it down by zone. And then we can even talk about the troubleshooting. What I've tried to do with the troubleshooting is incorporate it into the learning tools. So when we're talking about each zone and how we're fitting and the goals we're fitting, I'm incorporating some of that troubleshooting. But again, if we have any questions specifically about a case or any problem areas that you're seeing with Sclerals, feel free to add those in as we talk about it. And then resources. At the end, I'll give you many resources to kind of get you to the next level. What I would say when you're starting out is the first few patients and selecting those first few, just keep it really simple. Try to get the slam dunks to get your feet wet, to really get those easy fits in first, and then move on from there. So we'll do some basics. Obviously, I have to assume that not everybody knows everything and the fitting goals around Sclerals, since this is 101. So just the basics that we think about Sclerals and when we're fitting these patients is, let's vault that entire cornea. What are the advantages to that? We want to avoid corneal touch and have some clearance between the front surface of the cornea and the back surface of the lens, right? We want to have some clearance between there to create this nice layer of tear and saline. We have that clearance, so that's tear and saline that corrects all that irregularity. When Scleral started out, it was mostly, when they became popular, it was mostly for those irregular corneas. And another goal that we'll talk about is landing outside the limbal area, or the limbus, and how those philosophies have changed a little bit. And it can be specific to practitioner on what they try to do in their fitting philosophy. So we'll talk about what we've learned as a company in our manufacturing and having our lens out for about 8 years. We have about 200,000 lenses on eye, and that's after the returns. So we have a lot of data, a lot of clinical data that we've gathered on that, and that's what we put behind our fitting philosophy. So if you haven't fit Sclerals and you're wondering these advantages, they started out, again, really becoming popular 8 to 10 years ago. MD/OD practices mostly, where they're seeing a lot of challenged corneas, and they started out really mostly with diseased corneas, corneal ectasias, cone patients specifically. And once we started to fit these patients, we started to see all these advantages of a scleral lens. So when you're talking about comparing a scleral lens, a GP scleral lens, to a corneal lens, we found out all these benefits. So scleral lenses are extremely comfortable when they're well fit. I say soft lenses are not comfortable because they're soft, it's because they're large. And part of that is that edge to lid interaction. So when I'm blinking over a corneal lens, my lids are now banging or hitting the edge of that lens, causing some discomfort. So there's no lid to edge interaction on these large scleral lenses, which is really nice. That lid goes over that nice smooth front surface. And another thing that we have problems with corneal lenses as opposed to Sclerals is centering. To try to center a corneal GP over a steep cone is very difficult. That corneal GP will go to path of least resistance, and it will vault or center on that apex of that cone where these sclerals are vaulting that cone so it doesn't have control of that lens. Having that clearance over the cone, we have now the cornea is not dictating the control where the sclera is actually dictating that. So sclerals will center very well. Some of these will decenter inferior. We see that most common, and then inferior nasal, but it's still a large enough lens to have that optic zone have a great effect on that visual acuity and not have too much decentration. So they center well. We know about the hydration to the cornea because of that saline and tear behind the lens. It's really good. We'll talk about some of the other conditions, but a dry eye patient, if you think about that dry behind the lens, even with a corneal lens, how that can affect the fit of that lens. Well, with sclerals, we have all that saline and tear behind the lens to hydrate that cornea. Going back to lid to edge interaction, there's very little movement with these. Most of the time, none once that lens has settled, so they won't pop out. And another nice thing that we don't always associate with sclerals is when we think about the adaptation period of a corneal GP, we will have a patient in a corneal GP wear the lens the first day for a couple hours, the second day add a couple hours, and then we incrementally add on wearing time. And after about 2 weeks, they can wear a lens for a full day if it's a corneal GP. Well, with scleral lenses, not that we recommend the patient wear the lens the first day for a full day, but there's very little adaptation, meaning the discomfort and adapting to that discomfort. So some of these patients can go a full day straight out of the gates that first day. So there's very little adaptation period or no adaptation period. So those are all the advantages we saw. Again, we started out really fitting these challenge corneas, mostly the corneal ectasias, the cone patients. But as we moved on, we've seen all of these other conditions come into play. And we know when we vault all these irregular corneas, it's a lot better for that patient. We can have that saline and tear, correct all of that corneal astigmatism. So we're seeing, and we're fitting all of these types of patients. We're really seeing an influx of LASIK patients. So post LASIK, 8 to 10 years out, they're coming back and they have 2 diopters of cylinder, of spectacle refractive cylinder, and they have this irregularity where they're flat centrally in that mid-peripheral steep area. So it is nice to use that scleral for all that irregularity. If you're just starting out with sclerals, you have to open up your thinking too, that it's not just these irregular corneas that we're using sclerals on now. As we fit more and more of these patients, we're learning that there are advantages even for normal corneas, be it dry eye patient corneal surface disease, which we now have FDA clearance for the therapeutic use for ocular surface conditions and dry eye through the Boston materials, the XO and the XO2, and then the Conimac materials, the Optimum Extra and the Optimum Extreme. So those are high DK and hyper DK materials. So they had that approval. So think about that, adding that to the repertoire of the patients that we're fitting. And then beyond that, we're also fitting normal corneas. And this can be anything from just high astigmats, older population, again, going back to the dry eye patient, presbyopes, because we do offer a multifocal, and we're seeing a lot of these, a lot of athletes. So the lens is large, we get the visual acuity of a GP lens, and this lens won't pop out, and you're not getting dirt or debris behind it. If you think of an outdoor sport or even an indoor sport, that gives you the best possible visual acuity with the scleral lens. So I say all that to just say, make sure that you're looking at the broad picture. The big thing with normal corneas is trying to justify that cost to a normal cornea patient. And I think the easiest way to do that, or if there are conversations with these patients, is the quality of life. You have to understand what they're looking for in the quality of life, and then you can basically put that into how the scleral is going to help that quality of life and show the value of that scleral to that patient. Sclerals aren't going to be for every normal cornea patient, but if you're enhancing their quality of life, they see the value in that. So it is about the conversations and how you can do that. When we're getting started with Sclerals, it takes setting up, and it takes some pre-work to know before you get that patient in there. Now, with us and our philosophy is we're always going to use a fitting set. And as we get more and more machines and devices that are measuring more and more area of a cornea and outside the limbal zone, we are getting better and better at first fit success. But those machines, be it an eGled or an SMAP 3D or a Pentacam, which we can get 18, 19, 20 millimeters of information now, okay, those still only help with choosing a fit set lens in most cases and getting a lens on the eye, because we still have to over refract over that lens. So we need a fitting set. So when we're getting those first patients in, we want to make sure we have everything that we need. And in our fitting set with our Atlantis design, that's our scleral design, we provide you with everything you need to fit those first patients. So the DMVs for insertion and removal, we have a large DMV and a small DMV, insertion DMV in most cases, and removal DMV. The large is really nice to balance that lens, because we know we're going to fill that lens with the saline. So we provide those. We provide you some preservative-free saline, and that can be off-label, the inhalation saline, or now most of the material companies have come out with their own preservative-free saline. Some of these have extra or added benefits, like the neutrophil from Contumac. So very accessible now, readily available, but you'll need that preservative-free. If you don't have preservative-free saline in your office during the trial fitting process, you can just use any saline, even if it has preservatives, due to the fact that you're not really going to have that lens on for 5 or 6 hours. In that fitting process, it's going to be 30 to 45 minutes, and we're not too worried about those preservatives having some negative effects to that cornea. So if you're really desperate, you can use other salines that have preservatives or tears to actually do that trial fitting. I always have GP cleaner and conditioning solution. If you're using the fit set and it is in a dry state and you know you're going to have a patient the next day, I would recommend that you hydrate and put some lenses in a conditioning solution to have them wet. When we take a lens that's in a dry state from a fitting set and we try to apply that lens even after cleaning it, you will see a front surface not wetting a lot of times. We want to really condition that lens and get it hydrated, even though it is a GP lens and it's not really absorbing that conditioning solution. Dispensing towels, which is nice because we do have all that saline in the fluorescein that we're going to have. We want to protect the patients from that. And then we include in our set a little pen light. So this makes it easy once we apply the lens to check for bubbles and to see our quick clearance. It's really nice to have that pen light available and quickly check for bubbles instead of putting that patient in the slit lamp to see if there are any bubbles. That pen light really helps. So just some things that you can prepare yourself and have readily available for that patient as you move along with the fitting. So as we get into the fitting philosophy, again, this is our philosophy, and I'll give you the reasons why we chose what we chose as our philosophy. And it may differ from other sets or even practitioners or colleagues that you've talked to. So we have 2 generations of our Atlantis design. Generation 1 is where we started, and again, we had that out for about 7 years. And this year, we introduced Generation 2. So Generation 1, our philosophy was keep the lens smaller, but still vault most of the corneas. And we started out in Generation 1 with our starting point being a 15.0 diameter. And the 2 main reasons for that was we wanted to make sure that patients did not become discouraged with the application and removal process. In all of our studies and in all of our questionnaires, top two reasons patients don't go into Sclerals: cost, and then application and removal process. So our thought process was, let's keep the diameter as small as we can while still fitting most of the corneas. That way, a smaller lens, it's a fact, is easier to apply and remove. So we kept it smaller and we kept it at a 15.0. The other reasoning behind that 15.0 diameter at the beginning 8 years ago was because we thought at a 15.0 millimeter cord, I'm still landing outside the limbus, but at a 15.0 millimeter cord or diameter, there was very little astigmatism or very little toricity between my meridians at a 15.0 millimeter cord. We thought all the toricity started at a 16.0 millimeter cord or beyond because of the muscle insertions. Well, now going back to the instrumentation that we have out there that can measure these beyond the scleral, we know that even at a 15.0 millimeter cord, there is toricity, all right, even at a 15.0, and we know that as we go larger, it creates more toricity between our two meridians, and we'll talk about that in our edge design. So in our generation 1 set, 15.0 was our standard lens and our go-to starting point. And those, we have 200,000 lenses on eye. 15.0 made up 86% of those lenses. So 86% of the time when we put a 15.0 millimeter lens on, we could fit that patient. And just now we've gone to a 15.5 standard diameter. So just going up a 0.5 millimeter, we have increased that fitting percentage from 86% to 96. It's between 96 and 97% of the patients that we see now are fit in the 15.5. So our starting point is a 15.5 diameter. And if you think about that starting point, we want to land outside the limbus. That's one of our goals with a scleral lens. Even if we had a large HVID, okay, average HVID is 11.8, at 11.8 to 12.0. Even if we had a large HVID at 12.5, I'm still landing outside the limbus with a 15.5. That's giving me 3 millimeters of extra mass landing beyond that limbus, or 1.5 millimeters on each side. So this will fit most of those corneas. In our set, the nice thing that we've done is we talked about all those conditions. Now the 15.5 does not work on everybody. When I come to the end of my rope at the 15.5, I go to a larger lens. And the reason I'm going to go to a larger lens is to create more sag. So a larger lens gives me more sag or more depth in the lens. So that's why we have these larger lenses. If I have somebody that is highly irregular, a lot of times a post-graft patient or a central nipple cone where I really, really need more sag in the lens, I'll have to go to that 16.5 diameter. In the set, we also have a smaller diameter. So we give you the 3 diameter options, and this is mostly used for those normal corneas we talked about. It could be a normal cornea, a smaller HVID. We do this a lot of times on presbyopic patients, if they have small fissures, Asian populations. So the 14.5 is a nice option for those patients, but we still do put these on irregular corneas. We can still vault a lot of corneas with a 14.5 diameter. So in the set, you have all of these options. It gives you enough options to fit any cornea you're really seeing. We also provide other diameters in between this and beyond this. So our diameters go from 14.0 to 17.5, just in case there is something highly irregular or something you need to vault, like a penguicular pterygium, where you really need a large lens. And we'll talk about that also. So the fitting set, going back to what do I need to know and what am I doing and where do I start with this fitting set? So we make it very easy. We color code our lenses in the 3 diameters, so it makes it easy for you. And we just pick a starting point. Again, I said the 15.5 is our nice starting point. So we'll start with the 15.5 on any patient. And we just want to put a lens on there and start the evaluation process. You can see we've got 6 sags in our 15.5 diameter, and they're 200 microns apart. So if you're looking at the cap of that lens, you can see we list the sag, the diameter, and then the edge. Well, the sag is the most important. We really don't want to think in millimeters or diopters or anything like that. We really want to worry about sag. So the depth of that lens, and then once we put that lens on, the relationship of the sag of that lens to the cornea. So how much clearance do we have? So we put a lens on and then we work from there. We can increase our sag if needed or decrease the sag if needed by changing lenses. In our design, we can also manipulate this sag, the central sag, without affecting any other part of the lens. So again, you'll see what's labeled on the vial, and we're going to go through each of these to tell you what you're seeing and then what we're looking for. With our design and most designs, we fit from the inside out. We want to fit that central area first, and then the limbal area, and then the scleral zone. And there's a reason for that. Most changes on scleral lenses come from the scleral zone. So meaning if I fit a patient and I'm seeing that patient on a follow-up visit, the changes that are most made are to the scleral zone because of the settling process. Every scleral lens settles. So that settling process can be a little bit unpredictable. And then we have to change the edge. If I do my due diligence centrally and limbally with my amount of clearance, I know 99.9% of the time, even after that lens settles, I'm still gonna have my clearance in these two zones. What's the most unpredictable is what happens on that edge. So why I wanna start from the inside and go to the outside and have the outside evaluation last is I wanna give as much time as I can to let that lens settle, all right? We gotta give that time. So back to the vial label, looking at our lenses and you must be aware and know your fitting set before you start the process. So know what you're looking at, know the information, know the adjustments you can make before you start the fitting process with that patient. So on our lenses, we put a nice identification mark, which is lasered in the lens, so you always know what lens you have on. And in case you mix the lenses up, you'll know how to get that lens back into the right spot into your fitting set. We label the sag, which is most important in that central area. This is important to know. This is central sag. So from the edge of the lens to the back center surface, the central sag of the lens. And again, it's very important to know because this is what you're going to base all your clearance off of. If you're going to change the amount of clearance you have or want, you're going to do it through that central sag. We have our diameter, and we've talked about that. And then we have our edge. So we have our edge here, and we're going to talk about what that edge looks like. You can see here, we have an edge that is a toric edge. So in one meridian, the 0-180 meridian, we've gone 3 steps flatter than standard, and we've gone 3 steps steeper than standard in the other meridian. We're going to get into that and why we do that and what it looks like. Important also to know is what the power of the lens is, obviously for your over-refraction process, and then the thickness of the lenses. The thickness of the lens is important because most practitioners are using their slit lamp to evaluate my central clearance. All right, so you need to know what the thickness of that lens is to do your comparison to your fluorescein or your clearance, and we're going to show you that. So important to get familiar with your set beforehand and know what you're looking at. So again, we want to work from the inside out. So let's start with that central zone. We talked about the settling process. Every lens settles. How much is the lens going to settle? Again, unpredictable, but we know in our lens, because of our design, we see 50 to 150 microns of settling. Now, settling will happen differently between lens design and patient. So depending on what design you're using and depending on the patient, the settling process will be different. We know from all the lenses we have on eye that our settling process is from about 50 microns to 150 microns. Does that mean that every patient's going to fall within this? No. we're taking the majority of the corneas or patients that we've seen in fit and putting that data together to give a good range. For a lens to fully settle can take 5 or 6 hours, studies have shown. Studies have also shown that half that settling process happens in a 20 to 30 minute period. So most of the time, practitioners are only seeing a patient or a lens on that patient for 20 or 30 minutes. So I go back to letting that lens, giving as much time as we can to let that lens be on the patient and evaluating that edge at the end. All right. So what are we looking for? What are our goals with this when we first put the lens on? So we want to make sure that we have some clearance. If we have bearing, like here, or in the middle, some touch, there's a big difference between bearing and slight touch. We do not need to evaluate that lens. There's no reason to look at this lens because we know we need a deeper sag. And this is what we're looking for in the top right-hand corner. Absence of the cornea, all the fluorescein. I'm not sure how much clearance I have, but I know I don't have touch. So I can start my evaluation process on this lens. And what we're looking for is at least 200 microns of clearance upon insertion, and we want that over the steepest part of the cornea. So the apex of that cornea. I want to look at the steepest part because if I have clearance over the steepest part, I obviously know I have clearance over the flattest part. So 200 microns upon insertion over the steepest part of the cornea. And what we say in our fitting is 200 to 400 microns. If you fall within this range, that's the wheelhouse. That's going to give you supreme comfort and visual acuity. So if you fall within that range. Now, sometimes you can start out with more than 400 microns. Again, you're going to see some of that settling. Some of the problems, now back to the troubleshooting, we see with excessive clearance is you distort the visual acuity. So if I have too much clearance and I have too much fluid behind the lens, I'm getting that fishbowl effect. My visual acuity is not what I want it to be, not best corrected visual acuity, and it's distorted because I have too much clearance between the cornea and that lens. We have also seen that too much clearance can cause fogging or haziness. So you get buildup behind the lens because we have so much room and so much fluid and tear behind there that buildup stays there. With sclerals, it's almost stagnant and we don't get much exchange of fluid. So any buildup that gets behind that lens tends to stay there. So if you can reduce your clearance, it can help with that fogging or haziness behind the lens. All right, and going back to the over refraction or good endpoint on the over refraction, sometimes we see crazy amounts of astigmatism or over refraction still because there is too much fluid behind there. So look at your clearance, know that you're going to get some settling, and do your over refraction to determine if you have too much clearance. And comfort's going to be part of that too. I'm consistently asking the patient about comfort, especially upon insertion. I want to know exactly if they have any discomfort and where they have that discomfort. Now, once we get that lens on, we can start the evaluation process if we know we don't have touch or bearing. And that evaluation process is very easy through the slit lamp. And it's very easy with a white light. It's the best. The blue cobalt is a lot harder to pick up the front surface of that lens. We want to do an optic section, and we want to pick up that glare or the reflection on the front surface, which is here. And you can see that thickness of the lens, and then our clearance and our cornea. And I'm sure everyone has seen this, and Ferris has a nice chart that shows you the clearance values, comparing it to the same lens and different thicknesses in that fluorescein. But in this case, we're comparing that lens, that dark area, to the fluorescein, going back to what is my lens thickness. So if I know the lens thickness is 300 microns, then I want to do what I want to look for is a 1-to-1 ratio, right? If I look at the lens and it's 300 microns, and my goal is to get between 200 and 400 microns, if I compare this thickness to my fluorescein, a 1-to-1 ratio. So the amount of thickness of the lens to the amount of thickness of the fluorescein, if it's equal, I know I have about 300 microns of clearance. So we should also know that when we're fitting irregular corneas and we're seeing not a spherical cornea, we're going to see differences in thickness. You can see differences in clearance. We can see superiorly, we have a lot less clearance than we do inferior. So it's important. Steepest part of the cornea, we want to get that evaluation. We're going to see differences, but we want to make sure it's the steepest part of the cornea. All right, here's some examples of the differences in clearance. You can see here, a little difficult to see, but the thickness of the lens and barely any clearance there. And then as we move to the right, you can see we're building that. So all we did here is we went to a steeper lens or more of a corneal sag, central sag lens as we're moving up. You can see inadequate clearance, probably pretty adequate centrally. And look at the inferior again. We have a lot of clearance down here. We'll talk about our design and how we can control that in our limbal zone. And then you'll see sometimes excessive clearance where you can see the thickness of the lens and we're seeing at least 2 times that thickness, if not more. And we'll probably have to reduce that as we go through the fitting process. With an anterior OCT, this is a nice advantage if anybody is using this type of equipment. They're really, the manufacturers of OCTs are catering to scleral lens fitters. They see an opportunity with scleral lens fitters to really open up their market, and so do we. They're really catering where they're giving us wider views. The cost has come down, and most of these are very easy to operate where they've gone to a touch screen and it automatically lines up. So on an older OCT, you can see that we can get 7-8 millimeters of information. We take a snapshot of that central cornea. We can see our corneal thickness here, the front side of the cornea. This is the back side of our lens and the front side of our lens. So all this is the lens thickness that we talked about. And here we have our measurement of clearance. So with an OCT, it's quick and easy. And we simply have, in most of these OCTs, they give you a little icon. It's a ruler that you can pinpoint the back surface of the lens, pull down to the front surface, and you get an exact measurement, in this case, 375 microns. So very quick, very easy, and this can help kind of get the flow of fitting. If your technicians are the ones doing the OCT, you can tell them the goals of the central zone, even the limbal zone, and getting the view of the edge also, to look at those OCTs and make sure it's falling within your goals before you even see the patient. A nice thing that we've done to make it really easy, especially when you're beginning to fit these lenses, is look at what your result is for that trial lens fit or what's on the patient, and you can simply go through this decision tree or design chart, pick out what you're seeing. If you're seeing 50 to 200 microns, it gives you your next step. So what adjustment do I make through this decision tree to make it really flow nicely and easy? Of course, you can use the consultants for this, but this makes it very quick and easy to see what you have. You have your goal over here to evaluate your situation, and then what is my step, or how do I move on from that situation and create my next lens, or create the next, at least in this zone, what do I change? So a nice decision tree for that. So let's stop there. We've gone through the central zone, some of the patients. Do we have any questions? So let's see. So do they have improvements? Can we fit them with scleral lenses? What about, okay, so that's more of an advanced question. We can address that individually. We can talk about that. It's just in a question. So we'll talk about that if you want to individually talk with Santiago or I. Any other questions? We'll move on. So let's go into the limbal zone, again, working from the inside out. The limbal zone, with our design, if you do your due diligence centrally, 99% of the time, you're going to get your limbal clearance, except if you do have these irregularities that you may need to manipulate that limbal area accordingly. And you see, a lot of times it's on these post-RK patients or post-LASIK patients where we have a flat central area, a steeper mid-peripheral, where we really need to get over that mid-peripheral area and have that steeper mid-peripheral, but not get too much clearance in this flat area. And we can control that through what we call the limbal zone, which extends from our optic zone out to our edge. And in the limbal zone, you really want to get about 100 microns of clearance. This will vary upon patient. You're not going to get exactly 100 microns. And I will say that having a little less can help in some situations. Most of the time, more than that can cause different situations, which we see here, going back to that fogging or haziness, too much clearance. And we can see some of that. We've seen some hypoxia in that limbal area if we do have excessive limbal clearance, just because we have so much saline and tear behind there. And then that has to go through, you figure, the decay of the lens and the thickness of the lens, and then all of that fluid. And then conj, when we look at these patients and how soft their conj is, some of these patients will get the prolapse where that tissue is actually coming underneath the lens and forming in that limbal area. So controlling that limbal area is totally independent of our central area and our edge or our scleral zone. So I can simply move that up or down accordingly. In this case, I probably want to move that up if I'm getting that buildup behind the lens. If I'm seeing that, I can move that up or down. So independently, I can move my limbal zone without affecting the central zone or the scleral zone. And another nice thing in our design that you can do is the highest part of that limbal zone. So this blue area that we see is the highest part of the limbal zone. It's representing the highest part in our standard lens. If we go back to the fit set, all the lenses in the fit set have a standard limbal zone, all right? But you can take the highest point of that limbal zone and move it to the center of the lens, closer to this optic zone or central zone. You can move it in towards that zone or out towards our scleral zone. This is really nice. This is nice on post-LASIK. So going back to that patient that has a flatter central area, we know that in post-LASIK patients, we're seeing 6-7 millimeters of treatment area or flat area, and then they gradually steepen. And the steepest part of that mid-peripheral or paracentral area is usually at 9 or 10 millimeters. So in this case, I want to move the steepest or highest point of my limbal zone to that highest point, which would move it in from standard. And you can see it's represented here with laser marks. So standard is this middle line. If I move it in the highest point, it's going to move a millimeter in towards the central zone. And then just the opposite, if I have a PMD patient, sometimes a cone patient, and the steepest part of that is out towards the edge, I can now move that highest point out to the edge. You only have 3 options, one in or one out, and it goes a millimeter in towards the center or out towards the edge. I do have a question. This portion will, okay, Santiago's got it. We're talking about the flatter central corneas. So again, we can just manipulate our limbal zone up or down. Going back to my evaluation process. So what do I want to see? What is my goal? What am I seeing? And then what change do I make? So if I had touch or bearing paracentrally, I can increase my limbal zone, and then I can move the position. If I've got it at the limbal area, I can simply just increase that limbal zone, moving it up at the same area it's in. So you have those options up or down and in and out, okay? Very unique to the limbal zone and designs, but we need all these options. Even if they're not utilized that often, we do see these patients, and we're trying to fit as many patients as we can. So moving again out to the edge, and really, if you've ever fit sclerals, and even if you haven't, it's good to know that the edge is everything. Most designs are going to be very similar from the edge in. So your central zone, your limbal zone are very similar in their abilities. We have some unique situations with ours, but the edge is the most important. I told you that most of the changes will come on the edge. So it's important to know what we're looking at and getting as much information as we can outside that limbal where the lens is going to land. And this is some nice clinical data. Pacific University does a great job, and Pat Caroline, on really getting us as much information as we need to fit these patients or to have better fits on these patients for long-term success. So going back, we talked about, is there a difference in your meridians, in your 0, 180, and your 90 meridian as we move beyond the scleral or the limbal area? And we used to think that there was very little when we were at a 15 millimeter cord. But we've since learned that even at a 15 millimeter cord, there is significant toricity. So a difference between each meridian causing toricity. And we see as we go larger, we know that there is more toricity, and the corneal toricity has nothing to do with the scleral toricity. So remember that. It's totally different, and it has nothing to do with the corneal toricity, but it increases as we go further out. And this really gave us or enlightened us on how much that can be. So even at a 15 millimeter cord, looking at how much toricity there is, we know that there's a significant amount. There's not a right or wrong answer on exactly how much toricity at each diameter. But when we looked at it, and when we looked at the studies, seeing all of these advantages of putting a toric haptic or toric scleral zone helped with all of these things, including comfort, because we're aligning with that sclera a lot better. So that comfort has increased for that patient. The centration, we talked about the decentration. Well, if we do have a well-aligned lens, it centers, and it can bring that lens up and center that lens significantly better than not aligning with that sclera. And its stability. So we use the stability or that toric haptic. On that stability, it helps with our front surface toric. So when we're going to a front surface toric, if we truly have residual astigmatism, we need to make a front surface toric. We make a toric haptic to improve the stability of that lens, and that will help with not having rotation on that lens. So that stability stabilizes the lens so you can make a front surface toric. Probably a little more advanced than we want to get, but it really helps. We'll talk about the toricity and the amounts and what we do on the edge. We have also seen some benefits in that fogginess or haziness behind the lens. We've talked about this several times, and the troubleshooting and what you can do to help with that. This is another avenue. Putting a toric haptic or toric scleral zone on that lens can help with that. And then going back to that over refraction, we have seen on a decentered lens where we have a spherical haptic or scleral zone, sometimes we get false residual cylinder. Well, when we center that lens better, we see that residual astigmatism or cylinder go away. So we're getting that because of that decentration. So centration is very important, and it really does reduce some flexure in situations. We rarely get flexure on our design, but in those rare occasions, a toric haptic can help with that. We try to avoid going thicker on a lens just because of the thickness of the lens, and then getting through all of that fluid, saline, and tear can reduce that oxygen getting to the cornea. So the toric haptic will really help. So if we look at that and we look at all these studies, and now we come out with generation 2, our philosophy is we're putting a toric edge or haptic on every lens. So this is back to the fitting set. So we told you we have 3 diameters. This should cover all those corneas from normal up to extremely irregular. And even on our normal cornea or smaller diameter, we're putting 50 microns of toricity. So a very small amount, very small amount. And then as we go larger, we told you there's more toricity between the meridians. And you can see that in our larger diameter. So we're going up 1 millimeter, and we're now putting 150 microns of scleral toricity. So we've gone up 100 microns for a millimeter of diameter. And as we go further away from this, another millimeter of diameter increase, and we're putting on another 100 microns of toricity. And you can see, going back to our fit set and looking at that edge, to get that 150 microns, we've gone 3 steps flat in one meridian and 3 steps steep in the other meridian. So each step is 25 microns. So this would be 75 microns flat and this 75 microns steep, creating 150 microns of toricity. All right. We're looking at the edge. What we're looking for is the land out there beyond the limbus to align with that sclera. We don't want to see any blanching, whitening, disruption of the vessels at the edge. We need to make changes with this. We'll talk about that. This is the conj prolapse I talked about. This soft tissue, when we have pressure here, the tissue has come underneath the lens and is formed underneath there. We talked about how we can control that limbal zone to release that. And actually, some practitioners reduce the limbal zone to push that tissue back. You may even see sometimes the tissue coming out over the edge, so a larger diameter may help with that. It's one of those situations where it's really a search and destroy. The settling process, as we alluded to earlier, is very important. We know, again, 20 to 30 minutes, we're going to see half of the settling of these lenses, but 5 or 6 hours for a lens to fully settle. My pro tip is, if you see anything you don't like and you've only had the lens on, anything you don't like in the scleral zone, meaning whitening, disruption of vessels, impingement, blanching, if you don't like anything in that 20 to 30 minute settling process, make the change. It will not get better as that lens settles. It's just going to get worse. And you can see here, here's an OCT, front surface of the lens, edge radius lens, and here's the edge. And you can see that tissue pressing down so much on the edge, it's pushing the tissue underneath up into the limbal area, and the tissue's even coming out over the edge of the lens. So obviously we would need to make a change on that. So alignment with the sclera, very important. We want to make sure we're looking 360 degrees. So all the way around the lens, and check all the gazes. Patients are not always looking straight forward all the time. So we want to make sure that we're looking in all 4 gazes. We want to make sure all 4 gazes when we're doing that evaluation. And comfort and fit go hand in hand. So an extremely well-fit lens will be extremely comfortable. And we can tell some of these things. So as we look at troubleshooting and what we see on these edges, again, what's a tight edge, what's a loose edge, and we can go down the list and what we're seeing with these, there's a couple things that we should remember. It's the information that you're looking at, or if you're talking to a consultant, should involve 2 things: what you're seeing and exactly where you're seeing it. So if you look at this picture here, we're seeing that lens that's tight on the edge, and it's on the very edge. So that's important to a consultant or to you. You can see the vessel disrupted at that very edge. So this change may be different if I was seeing that inside the edge and it was a disrupted vessel or an area that I'm seeing that blanching inside the edge. Those are 2 different changes that we're making. So just on the very edge, a tight edge can be comfortable even at the beginning of the process, but that sustained comfort throughout the day deteriorates when you do have a tight edge. good initial comfort, but will not last. Some of the things that we see or we do, we can put some fluorescein over that lens and see if we're getting any of that fluorescein underneath the edge or even underneath the entire edge behind the lens. And a spin test, so simply rotating that lens left or right and spinning that lens can help to see. It should move very freely when you do that spin test. So those are some things that you can do on those tight edges. When I'm looking at a patient or if I'm talking to the patient, going back to initial insertion, we want to ask about the comfort. We want to know immediately if there is any awareness or discomfort, and then we want to specifically target those areas when we do the slit lamp evaluation. The other reason we're asking is, in this case, if I've got edge lift, so if I'm seeing or they are feeling any edge lift, I want to know if that edge lift is what's causing discomfort or awareness. And then I want to make sure that that edge lift is dissipating as the lens is settling. So at the beginning of the fitting process, how does it feel if you're feeling it anywhere? And is it discomfort or awareness? And then throughout the fitting process, how does it feel? Where are you feeling it? Is it getting better? And that way I know if I still have sustained awareness at the end of the fitting process, then I can make a change with edge lift. I would caution that I don't always make a change if I have edge lift when I first evaluate the lens, because once that lens settles, a lot of times that edge lift goes away. So it will settle, every lens settles, and a lot of times that edge lift goes away. Now, if it's severe, and I do see here in this case a bubble getting under the lens, yes, I'm gonna make a change on that. Decision tree makes it easier. What is my goal? What do I see? And what change do I make? You can see different evaluations. This is all in our fitting guide and makes it very easy in the process. Other things that you'll run into as far as an edge or lens design is obstructions out beyond or at the limbus, penguiculas, pterygiums, even blebs. And in our process, you have options when you have these. I know we see a lot of these in South America, and we can even do both sides, but what we do is we take a finished lens and then we simply cut out part of the lens to go around that obstruction. You have other options with this. If you don't feel comfortable in that, you can make a smaller lens, obviously. You may be back to a corneal lens. You can go larger and land outside that obstruction. So there's many ways to do this. We won't get into exactly how to measure and all that, but you know you have the options and all the consultants can help you with that. Other things that we see when we're looking at the surface, once we let that patient out the door, once we've given the patient the instructions and all the education, we know that it doesn't really last long with those patients a lot of times, even if we do the greatest job ever. So we've got to be aware that if we're seeing a condition or if we're seeing something, that we've got to target, again, search and destroy on what is causing that. We know that a lot of patients are not compatible. We don't have the greatest compliance. They can't have dirty insertion or removal tools. They are doing it with digitally. That can cause some problems or get something on the surface of the lens. Are they using unpreserved saline? So your best way to avoid these is when they come back for their follow-up and even their 3 months, 6 months, and we can talk about what that schedule is. Observe them cleaning the lens, observe them putting the lens in. Look at their case, look at their utensils to see if they are hygiene, if the hygiene is there that you want. Because if you're chasing your tail on these problems and you haven't asked those questions or seen how the patient is hygienically, then you're not going to know. What I'm getting to on the other end to avoid some of this is we can treat the surface of these lenses. So you may or may not have used tangible hydropeg, but tangible hydropeg is a great option for, we can't make patients compliant, but it helps with non-compliant patients in the fact that hydropeg is polyethylene glycol. it basically, in layman's terms, creates a super slick surface. If you don't know PEG, they use it on boats to go faster in the water. They use it on pills to slide down your throat. So it creates that super slick surface. And an MD came out with a formulation for contact lenses, and it's by Tangible Sciences, and it's super slick surface that bonds to the lens. So we put a lens through a plasma treatment to clean the lens, and then it goes into a hydropeg bath for 75 minutes, and then that formulation of hydropeg bonds to the lens and creates that surface. So if you have a high depositor, if you have a presbyopic patient, and someone that is having problems with the front side of that surface, because even though we have all that saline on a scleral lens behind the lens, the front side of the surface can still be a dry environment. So hydropeg really helps with that, and helping those patients really with those depositors. It really has a great effect. So that's an option for you. Also, the one thing with this is you've got to be compliant with the care systems, so know what care systems are approved with it. You can use ClearCare, Unique pH, or SimPlus with the lens for your cleaning regimens. But another nice option, just to not have problems later in that fitting process, or even down the line a year after you've fit that patient. So the follow-up schedule, this depends on you. I always leave this up to the practitioner. This is just recommended with sclerals. If we're talking about a challenged cornea, we like to see these patients. We dispense, obviously. I say 1 week because everything that's going to happen with that scleral will happen in a week. Some practitioners like 2 weeks. And then here, depending on the patient, this is more of a cone patient follow-up. Some doctors like to see the patient at 1 month. On your follow-up visit, so this 1 week or 2 week visit, so that first visit after dispense, an important pearl is to see that patient as late in the day as possible. So we want the patient to apply the lens in the morning, and then you're seeing that lens later in the day. So you're seeing a fully settled lens, probably a fully settled lens for the first time. So you want to make sure you're scheduling that patient later in the day. So now when you do look at that edge, you know that you're seeing a fully settled lens. And on that follow-up, or that 1 week follow-up, you're going through your steps again. What's my clearance centrally? What is it limbally? How does my edge look? Then you're asking the patient the obvious questions. How long are you wearing the lens throughout the day? What's your visual acuity throughout the day? How is your comfort throughout the day? And then observing them again, putting the lens on, taking the lens off, looking at that lens and that cornea without a lens on that follow-up, and then seeing if the patient is compliant. I would also say that due to the most warranty periods being at that 90 days, I would be scheduling that patient right at that 90-day warranty period. Now, we say 90 days, and we have actually extended this warranty period due to the circumstances we are now under in some situations, because you do have lenses sitting in the office waiting for patients to come in, and we're obviously on restrictions with that. So that's something you can find out from our consultation or through your account rep. But see them at that 3-month window if you do have a 90-day warranty, just in case you have to make an exchange. We say these are yearly replacement lenses. Again, all the pre-work and having all the things that you need in the tools at the beginning, but we also feel it's very valuable to send that patient on their way. We know compliance is a lot better when we provide the patients with the care system that they need, the utensils for insertion and removal, and how they can get these in case they're lost or anything that they need. We do provide them, or we want to provide them with the unpreserved saline. It doesn't have to be a year supply, but at least to get them started, paperwork, contracts, anything they need, we want to provide them with that. We have nice patient kits that we provide for you to give to your patients, so we can fit some Addipac unpreserved saline in here. Even the other salines will fit in our cases. Obviously a case, and we have a slot for the remover insertion remover DMVs, and then a mirror. So these patients can have this in their car, in their purse, whatever they want in case they have to remove that lens, you know, replace or replenish the saline behind that lens. So you have all these options to really get your patient underway. Insertion removal, as I said, I think this is something that there are a lot of great resources. We have great resources online on our website. We have a patient guide where you can hand this to the patient and it goes step by step through the INR process. We have videos on our website for this process, for the fitting process, for troubleshooting, anything you can think of with Sclerals and other designs we have on our website. We will be putting this specific webinar on our website. It takes a few days, but we'll be doing that also. And then we always try to use other resources. We're a part of the Scleral Lens Education Society, and they have an abundance of resources. Again, it can be application and removal. They have patient resources, everything you need to know about Sclerals. And then it can get into more of the care systems, more of the patients, and the billing and coding, which is very important in some situations, trying to do that. So we encourage you to use sites like this. And then there's other resources that you can use, and we can get that. You can obviously use us, which is at xlspecialty.com right here. And then we're part, you know, gpli.info is very nice for gas perms and scleral lenses. They have a lot of resources that they'll give you free materials for your patients. Insertion removal guides, care systems and compliance, so you can get free brochures for that. Anything you need to really get started with Sclerals and to help that patient be successful with those fits. Okay, so a lot of information. Let's go back and see if we have a couple of questions here. I think we addressed a few of them through the chat. Can I get the lecture? Yes, obviously, again, we will have this recording up on our website, xlspecialtycontacts.com. It should be in your email also, where you probably got the invite or when you signed up for this. If not, you can get with your rep and they'll give you all the information. There, Santiago has posted it. Any other questions that we may have, fitting philosophies, any questions that you have that we may be help? Fitting set info, good question. So we offer several different fitting sets. We showed you our large fitting set, which encompasses all three diameters, the 14.5, the 15.5, and the 16.5. We also offer a smaller diameter, not a smaller diameter, a smaller fit set, which is 12 lenses and is just the 15.5. So that's something that is up to you. I would contact us directly for the pricing and how we do that. Santiago is posting all the information you may need with that. So I think we've addressed that. Would you use Simplus to rub and clear care to soak overnight? This is a question. Would you use Simplus to rub and clear care to soak overnight, or Simplus alone? So I always leave that option up to you. Obviously, clear care is going to be your better option for that, for the overnight soaking. Simplus is simply a conditioning solution and all-in-one, and I don't feel like they are as good at cleaning as a clear care would be. So I hope that answers your question. How many times can we change the lens for the customer? Good question. So that depends on, I guess, your account and the exchanges. We have different exchanges for different situations. So that's something also, go onto our site or to contact your rep in handling those individual cases on what those exchanges are. And again, we have extended our exchanges because we know lenses are sitting there waiting for patients. Any other questions? Okay. Okay, if you have a question is the old set. If you have the old set, the old set will work. It's still a function of our design. So if you have generation 1 Atlantis set, which consisted of a 15.0 and a 16.5 diameter, yes, you still use that fitting set. We did not change the design of the lens. We have simply changed the manipulation of the lens and the zones. So the design is the same. You can still fit it with the generation 1. You just have more options and more manipulations of the zones. Okay. Is it possible to empirically fit? Good question. We truly do not empirically fit. We just don't, there's not a good correlation between a K reading, even a topography, as I alluded to, even the machines measuring out beyond the limbus and what that lens is. So a K reading or topography still does not help us. I've had cone patients that were a 55 flat K, and I've had RK patients that were 39 flat K, and they ended up in the same SAG lens. So there's not really a direct correlation. It's not about the cornea, it's about the vault of the cornea and then that lens landing. So it's really not easy to come up with an algorithm and fitting these empirically, even with all the information, even with the edge design, because we still need to over refract. So why not save that time or a patient visit and be able to overfract with a trial lens? I always like to see a lens on and then work from there and make those changes. Okay. We got another question. Can we have this training in French? As of right now, we don't have a translation into French. We do in Spanish. You'll have to contact Santiago for that. What is the relationship between base curve and diameter? I'm not sure what you mean by that. So our base curve, we can control our base curve and we can increase or decrease our sag of the lens through the base curve. We can also control that sag through the diameter. I'm not sure. Maybe you can ask it in a different way that would help me understand that. If I do any changes in the new design, like limbal zone and landing, does it affect the sag or the overall reference? So that's a tricky question. Yes, if you change your limbal zone, essentially it would change your central sag, but it also depends on how much you're changing that limbal zone. And if you're doing it in an overall full, so if I'm changing the entire limbal zone one way, it will affect your central zone. If I'm creating a toric limbal zone or a quadrant specific limbal zone, it'll have a different effect in that. The nice thing that we've done, if you do change the limbal zone, you can do a central sag adjustment and it does not affect your base curve. So I can move my central sag, increase it or decrease it accordingly without affecting anything else. So it won't affect the base curve, it won't affect my over refraction. Okay, another question. I mixed the lenses up. How can we know which is one? So the laser marks, we alluded to it earlier in the slide. There's a laser mark on each of the lenses. There is on the previous generation 1 set, and you can see that in the fitting guide where that lens laser mark is. And in the new set, we have laser marks also that will show that, and that's also in the fitting guide. You are in which state? We are in Georgia, Atlanta, Georgia. Was this recorded? Is it downloaded on YouTube? We won't put it on YouTube. We will be putting this on our own website, and it is recorded. Yes.
Hey Tony, I think you might have skipped a question from Elias in which he asks if we can use contact lens. 1 second.
The hydrochloric acid?
Yes, did you answer that one already?
No, what we highly recommend just unpreserved saline. Now, some practitioners will use an artificial tear, but it has to be preservative free. So I would stick within that realm because that fluid is staying behind the lens. So unpreserved saline, a combination of artificial tear and saline, but I would not recommend hydrochloric acid.
Fantastic. I hope that clears
Okay.
your question, Elias.
Okay. I think we have addressed everything. A lot of comments and questions. Thank you. To everybody, thank you so much for attending. Again, you can contact Santiago or me directly if you have further questions or any needs. Please be safe to you and your families. Thank you so much.